Okay. So I think while we wait, I will start off on one of the easier questions. What is so when once the history suggests possible BPPV, what are the maneuvers that you would do in your clinic before say to confirm that this is a BPPV? What are the basic maneuvers that you do? Sometimes, I mean, at least for typical, we are starting off with some very basic thing. What are the typical maneuvers? So what are the usual maneuvers that you would do in a clinic once you suspect a BPPV? Dr. Avinash, can we start with you, sir?
Yeah, I normally start with a McClure Pagnini supine yaw head roll,
Okay.
and then this is followed by a right and left Dixol pike primarily,
Okay.
because that way you have tested all the three semicircular canals on both the sides.
Okay. So what I mean, so when you say you start with a supine roll, so sometimes this becomes hard to do all the maneuvers if somebody is having extremely fearful. Basically, that's what most of the time that's very hard for us to do the testing. That patient is having a lot of fear when you do the testing that they will have the
Yeah.
symptom. So,
So
what would you suggest? This is a order that you prefer that you start from the supine roll and then go to
the
the.
supine roll is an easier thing for the patient to be subjected to, number one.
Okay. Okay.
Before everything else, in fact, I do talk to the patient,
Okay.
prime the patient. Problem is, and what is BPPV? To be positive, patient is going vertigo
Mm.
and maybe but vegetative symptoms, the testing and the maneuvers that. So the 10 minutes
Okay.
and maneuver importance. And I do keep I'm at a place where the videos are not available. I don't mind personal maneuver that is this going to do to you. So that makes things easier. So I think we are the fear of the patient.
Okay. So, of course, it is open to all the other panelists as well. If you want to add anything more, I'm happy to take you. I mean,
Yeah.
please feel free to contribute.
So may I add something?
Yes, sir. Please.
Yeah, I agree with Dr. Bislani, sir. But first of all, we need to differentiate between positional testing and positional maneuvers. So that's very important because positional testing is something which we test to check which side is involved and which canal is involved. And positional maneuvers are the therapeutic maneuvers which are done to reposition the particles. So if we are in case of positional testing, the first thing which I do is right dick sulfide, then left dick sulfide, and then I go for like Mercure Pagnini. Because posterior canal being the most common, I start with dick sulfide first. And in Dubai, we test all the four positions before going for the treatment. And I also do the supine straight head extension, and it is one test to check all the four canals. Like even you can check the posterior canals as well as anterior canals. Even I have seen that patient who has right posterior canal BPPV, even in the supine straight head extension, the posterior canal showing up the excitatory nystagmus of the posterior canal. So, like these are the various three major tests which are done for this thing. Dixal pike for posterior canal, right and left. Head roll, or like we can specifically call head yaw test. That is Mercure Pagnini maneuver testing. That is for lateral canals. And supine straight head extension or deep head hanging position. That is for testing the anterior canals.
So, before that, I just wanted to add one more thing. If before you choose which test to do first, is there anything in the history that tells you this is more likely one of the anterior, posterior, or or lateral canal? Is there anything
Yes,
at all that can tell you?
there's a thing.
Yeah.
See, if it's the posterior canal, the patient might give you a clue by saying, if I turn to my right, I feel the vertigo. Whereas in lateral canal, the patient is going to tell you whether whichever side I turn, right or left, I feel vertiginous. And a slightly more intelligent patient will also tell you which side the patient feels worse. So this is kind of lateral canal. Anterior canal will be bilaterally symptomatizing in most cases. Again,
Yeah.
side effect
There's one more. Can I add something?
more,
Yes, sir.
but anterior canal, the angle it makes with the sagittal plane, it's not the exact 45 degrees or so, it's much less. So the symptom can also appear on both the sides, and even the nystagmus can appear on right and left, whichever side it is. And then from the nystagmus, we of course derive which side is affected.
Sir, Sudhir sir, you wanted to add something?
Yeah. So from the history, sometimes you can get a big clue. If the patient says that he gets vertigo, he got it first time when he tried to get out of bed, it is probably posterior canal. Very often these patients even say that when they try to get up, they feel thrown backwards. And if the guy gets in the middle of the night when he's rolling over from one side to the other, without getting up, then often it is lateral canal. Of course, you have to, like Dr. Bijlani said, see whether it's bilateral, see whether it's uh, in what movement is causing. But if the person says from history that when I got up in the morning and I felt spinning when he tried to sit up, then very often it is posterior canal.
The reason I asked this is, so many a time what happens, most non-neuro-otologists, if they do a testing, it's most likely only the Dixon peg. Very rarely the people do a supine roll test. And I've seen that in common practice. When they do the Dixon peg, it's negative and they say, okay, fine, it's not VPPV. I think what sir suggested is quite right. From a supine roll to shifting to a Dixon peg can sometimes be easier for a patient, especially if the patient is very heavy. Sometimes it's actually easier to do a supine roll first and then go for the Dixal pick. Is that how you do it as well, sir? Is there any difference in the order that you choose?
I am not. I mean, if there is clearly from the history that it seems to be lateral canal, I would do lateral first. And in lateral canal, often when the person is seated and you put on the goggle, that time itself you see a little horizontal nystagmus. So the bow and yaw, I try to check in the sitting position. So you know often that it's going to be lateral canal. Then you directly choose that. I have not seen, though Dr. Asprella has told that, in seated position, you take the head backwards to one side and you see upbeating. I have not seen that happen much in our posterior canals. Somehow, I don't know. But the lateral one we see, the spontaneous sort of nystagmus on bow and wing. Okay, I'll just join. I'm going in the basement. I'll join in 2 minutes.
Okay.
Bye, bye.
So, just adding on to that, I think sir brought it up that minimally invasive testing that Dr. Aspila has suggested.
Yes.
So, does it make sense to use it routinely for everybody? Especially, of course, if you don't have a couch in your city, in your consultation room, I think that is the only way we can test. Is it something that we
Yes.
do routinely? Or,
It is worth. See, I mean, like, it's not. When I don't try to differentiate between positional testing and maneuver. If I do Dick Salpack and I get a severe upbeating, then there's no point wasting and making him do it again, because sometimes you try it again, it changes. So might as well convert it into an Epley first position and go on ahead. I don't know what the others do.
yeah, I'll take the, yeah, I'll ask the others also to contribute on this point.
Please manual test is positive.
Okay.
Because so couple of more steps and that's the reason, in fact, in my collection of videos, videos of the posterior canal, because I somehow feel very tempted for the patient.
So, Ajay sir, anything do you want to add on that, sir?
What I want to add is that, as the Dr. Sudhir has told, from the history, if the vertigo begins in the middle of the night or early morning when the patient is still supine in the bed, it's likely possible that it could be a horizontal canal PPPV. In that case, I do a bow and lean test, that is also called the head pitch test. And that is again very interesting. Many times we find that bow and lean test, you have given a sufficient time to bowing as well as leaning up to 1 minute in each position. You don't get any nystagmus. When you take to the head yaw test, that is the supine roll test, that should not be called roll because roll is this movement. So that is head yaw test when we do. We get a horizontal nystagmus, geotropic or apogeotropic. And then you again repeat the bow and lean test, then it becomes positive. So it is a bow and lean test is important. It has a secondary literalizing value, but always try to do it because in horizontal canal BPPV, the had your test elicits almost a similar nystagmus, invariably elicits nystagmus on head yours to the right and left, and you have to decide which is the involved side. And that is sometimes difficult when you don't have those VNG machines showing the snow phase velocity. You have to do it visually. Most of the time, you can do it, but in a certain patients, you have to decide which is the stronger or which is the weaker nystagmus in geotropic and apogeotropic variants of the horizontal canal BPPV to literalize that. So bow and lean test is always useful. And again, there is one thing, when you position the patient from long sitting to supine with head straight ahead, there is an entity called sit to supine nystagmus, or that is by the Italian groups, and I prefer to call it a lying down nystagmus. That has the same importance as the leaning nystagmus as far as the literalizing value is concerned. So always look for that also.
Yeah. Regarding the minimal stimulus strategy, I don't prefer to use that. I use it as a part of VNG. We do it for if we are not suspecting BPPV, then only we do minimal stimulus, not just to miss BPPV. But when I'm suspecting a BPPV, I go for actual positional test rather than going for minimal stimulus. And regarding the localization based on the patient history, some patients are very intelligent. Even one patient told me that I had doctor when I lie down, I have 7 spins. Even some patients are so intelligent, as opposed to there are patients who are not able to, describe their symptoms properly. And posterior canal, as Kothari sir said, like while getting up in the bed and while lying down, and in the night rolling is lateral usually, and anterior canal is in the daytime when they bend forward or bend backward, like lean. That can happen in posterior canal also, but usually anterior canal. That's what I find in the patients.
So, I mean, why the reason I brought up is that I just wanted to get your opinion on this as well. So, most of the time, I mean, as a specialist, as ENT or neurologist, the most of the VPP patients usually end up going to a physician or to the ER of a small hospital. They get given vestibular sedatives, and then they end up to you day 2 or day 3. It's very rare to see a BPP on day 1. Do you think that makes a difference about the minimal stimulation? If on a day 1, when the symptoms are extremely severe, do you think that is more likely that you'll get a minimal stimulation test positive?
Thesis may be missed by the vestibular centers, but I don't have seen many patients whose nystagmus, because I try it multiple times. I do MI maneuver and I do a loaded Tix-Alpine test, and anyhow I am able to get that nystagmus. That's what now you Vishal you say.
Yeah. So it all depends on how the canalith, like otolith burden in BPPV. In a given patient, if the burden is more, then even the minimal strategy will bring out that particular, this thing, stimulation or inhibition of the canal. But in my practice, where I go for actual testing, because here I don't see minimal stimulus strategy positive. And if they receive vestibular suppressant, as what sir said, it can suppress their symptoms, but nystagmus can be seen. And it is always good idea to do the actual positional test, like I feel. And if they are off the drugs, it is better. But I don't hesitate to do on the, even if they have taken the drugs, because it's not a good idea to send them back, because patients come from long distance and you stop the medication and then come. I don't do that. Like, when many a times it is positive, like it's not that you cannot get the typical nystagmus or symptoms, but if it comes negative, we can always recall the patient again for retesting.
Yeah, I think I'm just going to stop right there. I'm going to take one of the questions from the chat box. So somebody's asked this, patients will have the sitting up vertigo. What you talked about, the position change, sitting up from bed, having a dystagmus, vertigo. But testing with the Dixalpig being negative and a supine roll negative, no nystagmus seen. What would you do in such a patient?
In such patients, if the symptoms are mainly they get vertigo from sitting up from the bed, it could be sitting up vertigo. There are, in fact, three variants of sitting up vertigo. Number one variant was described by Skoko in year 2019. It is periampullary restricted posterior semicircular canalolithiasis and with a partial canalage jam distal to the periampullary region, that not towards the cupula but distal to the periampullary region. So these are the patients in whom you don't get any nystagmus in the head hanging dix sulfide position, and as you take him to the up from the dix sulfide position, you will get a very good nystagmus. So most of these patients in this COCO series, this was a small series of 15 to 17 patients. They responded to, they got converted into the typical variant. I have seen only one patient of this COCO 2019 series that I treated with the multiple sit-ups from the lateralized dexalpine position, and then that responded by getting converted into the typical periampullary variant. Probably the jam got crumpled due to multiple sit-ups. This is one of the variants, very rare. More common is the short arm posterior semicircular canalolithiasis. So, short arm posterior semicircular canalolithiasis, you get typically the nystagmus during either the half Dixalpike testing or a recently introduced term in 2024 that is called the augmented half Dixalpike testing. There is difference between them. What I do in my protocol, I do this Dixalpike test, and then if I don't get it in 1 minute and in nystagmus, I antiflex the head 60 degrees so that it comes around 30 degrees above the horizon and it makes it a half Dixalpike position. But that is not a augmented Dixalpike. You can say you have augmented the Dixalpike or you have converted the improvised the Dixalpike to a half Dixalpike position. I would get it is a improvised half Dixalpike testing. The augmented half Dixalpike testing means that the half Dixalpike testing was done normally. You have put a pillow, you have yawned the head to one side, and as the patient is made to sit supine, is made to lie supine, the head gets antiflex 30 degrees and making it the half Dixalpike testing. So you have done that, it is negative. You have done a Dixalpike test, that is negative. You have held the head hanging position for 60 seconds and then you anti-flex 60 degrees and then you get the nystagmus, which is like the nystagmus of posterior canal BBPV. That is ideally called augmented half Dixalpike test. Because sir. So this Kothari sir is telling something.
This thing was, should we change our protocol now? I had discussed once with Dr. Vats that when you're taking the patient down into Dix Halpike, before you take him down, you keep him in the half Halpike position, see is there anything, then take him into 30 degrees down. So what is the half Halpike is same as as if you're going to do Dix Halpike, but instead of taking the head 30 degrees down, you keep it 30 degrees up. And without a pillow or anything, you just hold it there. It's not there. Take it down into Dix Halpike. Then, as Ajay said, if you get posterior, you treat that. If you don't get anything, again, bring it up. Before you make him seated up, just stop at 30 degrees above. So it might become a habit and you might pick up more of augmented half Halpike by this, I think. Because if you get Dix Halpike kuch nahi aaya and then you bring it to the half Halpike and get, you can't call it half augmented.
So
Sir,
I think,
that
sir,
is technically.
one question I'm going to raise here. I think many of the attendees will be having this. How long do you wait in each position before saying it's negative, sir? I want everybody's answers on this point.
60 seconds.
At least
60 seconds.
60 seconds.
Okay. So does everybody agree on that, sir? Each position you wait for 60 seconds.
Yes.
Okay. Is it the same for the supine roll as well as the Dix-Alpine, or is there any variation?
True.
Both. And one more point
Avinash,
I wanted to ask, what do
the-
people do? Was this covered if the patient has a history of positional vertigo, but when he comes to you and you do the maneuvers, it's not there. What do you do?
Yeah, sir, I think that's where we started. That's where we started with this Dix-Alpine, half Dix-Alpine actually.
No, no, not even Dix Alpine. Talk about I think Dr. Watts put up a video recently. What is that? Some four-letter word maneuver.
that is MI maneuver.
EMI. So
MI maneuver.
EMI maneuver is for, explain that maneuver. Yeah.
See, suppose you are the patient has a classical history that I have got a vertigo triggered by little recumbency to the right, and you don't get any nystagmus during the Dix-Alpine tested for 1 minute, and then you do a half Dix-Alpine by augmenting it that the way I do after 1 minute. And then what you do is that again you make the patient sit upright. Suppose you are suspecting it to the right, you maximally antiflex the head and trunk to around 90 degrees and then rotate the head 45 degrees and maintain that position for a minute. And then you do a Dix-Alpine test. So the idea is that you are somehow trying to mobilize the otoconia so that when they are uh, he's put in the Dix-Alpine position, the otoconia will have a bigger mass to generate the cupular deflection. This is one of the hypotheses. And earlier, this was also called the loaded half Dix-Alpine test. But in that condition, the head was antiflexed only 30 degrees. The only difference between the EMI maneuver and a loaded Dix-Alpine test is the angle at which we antiflex the head.
Okay.
There's one more point that if we have seen this often in patients, and it stands to reason. If the patient you examine in the morning, that paper was posted in our group. If you examine the patient in the morning, you have a higher chance of getting a positive Dix-Alpine or positional testing than if you do in the evening, because the particles have got moved all over throughout the day and they get dispersed. So like Dr. Watts said, you do the DMI maneuver to sort of collect all the particles and make them into a bunch and simulate what is happening at night and get them all together and do it. But otherwise, the next thing you can do is call him in the next morning rather than evening.
And
Very true.
yeah.
I
Yeah.
prefer to call my patients in the morning unless they have a reason not to come in the morning. BPPV patients means come in the morning.
Okay.
Yeah.
Okay. I think that's a good point, sir. Sometimes when you see them in the evening, especially on day 2 or day 3, and somebody's also asked how commonly is many of these patients, how common do you see the spontaneous resolution of the BPPV on day 3, day 4, something like that?
As a joke, I've seen it sometimes. If a person has BPPV, my repositioning is done in another room by the technician. So if I examine him, I do a Dix-Alpine and I send him there, it's gone by that time. So sometimes just doing a Dix-Alpine can cure the thing. So
There's a
if
paper
you
on this.
really have a patient of BPPV, send directly for reposition. Don't even do a Dix-Alpine.
Yeah. As Bijlani sir said, there is a paper
There's a
on
paper on.
like repeated Dix-Alpine causing resolution. Why it happens is because the clump of the otoconia, when it is broken by repeated testing, suppose for example, and if the particle becomes small, the endolymph will absorb it. Like this was told in a recent Barani meeting, that if the otoconia becomes smaller, the endolymph can dissolve that otoconia if it is very small. So that's why repeated Dix-Alpine can lead to even natural resolution, and that these are the patients who tell that I took beta histine and I got better. Like many a times in beta histine or other drugs are given in the practice, and why these patients get better without doing maneuvers is mainly because it happens that because of their natural head movements, there is a natural this dissolution of particles, and natural resolution.
There was an earlier paper, I don't remember that, but the natural history for BPPV resolution is about 6 weeks for posterior canal and about 2 weeks for lateral canal.
That paper is
Lateral
by
canal,
MI in the Green Journal of Neurology, and mostly the lateral canal they recover as early as 4 days also.
yeah. So average 2 weeks and average 6 weeks. But
The-
that is why the beta histine works.
yeah, that is one of the reasons. Vishal, you told about the repeated Dexalpike. That is a well-established maneuver suggested by Bela Buki in year 2011 when he described the subjective vertigo or type 2 BPPV without
Yeah,
nystagmus and only retropulsion. So that is the theory one of the two theories he proposed at that time.
Okay.
yeah. And by the same group, as you said, Professor Belabuki, and in the same paper, Professor Luigi is also there. In that, they describe the causes of sitting up vertigo. One of the causes is short-arm BPPV or variants of BPPV. But we should also remember that it is very common finding in vestibular migraine that they get sitting up vertigo, and there may not be, just they have symptoms without having any nystagmus. This is a very common I see. And in fact, in any vestibular disorder for that matter causing vestibular hypofunction, because it's a head movement, head motion can lead to little dizziness. Even in vestibulopathy also they can have, Meniere's disease they can have, but most commonly it can happen sitting up vertigo is in the setting is BPPV. But of course we should remember about the other differential diagnosis.
Absolutely. So if a patient says he gets vertigo only when he gets up in the morning, it's often migraine. But if they say when they lie down also they get, then it is usually BPPV, even if the person has a history of headache, because it's not uncommon for patients with migraine to also get BPPV.
Yeah.
Yeah.
Sir, I think we've spent a lot of time on this testing. I think that's hopefully there's a couple of questions here. I'm just checking. Is there a change in the picture if the patient is on long-term beta histine? I think we already covered
Absolutely. Absolutely.
that. Yes, sir.
I have often seen patients if who they not in long term, even if they just take it for 2 days before come one day, you may not see. They call that, they say that beta histine does not suppress, but I have seen beta histine, the patient takes it and he comes, no, this time he stops it, and then I re-examine after a day, it will be there. So you will not see the nystagmus. So, and of course, if they're taking the cinnarizine and stimetil, it's even more.
Okay. Sir, and so just to conclude with this, I mean, when just initially we start with the diagnostic part of BBPV. I think we're going with what we do, history examination. So before we finish this, is there anything in the clues which would tell you this is a central cause of positional vertigo rather than peripheral? Anything when you are doing the testing that tells you this is central?
Testing
Persisting
or for the
nystagmus.
history?
Testing. We'll do the history and the testing, sir, because we're talking only about positional vertigo.
So, if the history tells you anything, if there's slurring of speech, double vision, anything else, headache or something else, then that makes you aware that it could be central. But if you examine the patient and you are getting patterns of nystagmus which are not fitting in with BPP, you get what looks like epigeotropic, but lateral canal, but it's not really behaving like lateral, or you get downbeating. And remember, anterior canal is extremely rare. So if you get downbeat nystagmus, even positional, very often it might be central. But if I've never seen a typical crescendo, decrescendo, upbeating posterior canal like pattern due to a central cause. I don't know about the other panelists.
Yeah, the same question to the rest of you as well, sir. I want your opinion on that.
There are a
Yeah.
few things.
Yes, sir.
Yeah.
Oh, Vishal, go ahead. Vishal, please
No, no,
go
sir.
ahead. No, no,
Uh,
no.
Go ahead.
First you go ahead. I'll come in later.
Okay.
Yeah. So one of the very important feature is, as Kothari sir said, is symptoms. What the patient presents with. If the patient presents with monosymptomatic positional vertigo, obviously the first diagnosis is BPPV. But of course we should check for other signs like deadly D's and other thing. But in testing, although theoretically, like we see that longer latencies, all these can happen even in BPPV, like not longer latency, no latency, and even longer duration of nystagmus. This can happen, but that could cause suspicion towards the other. But repeatedly, if you are doing the maneuvers and the patient is not getting repositioned, then it should raise suspicion. And I retest the patient same day. When I do the maneuver, I ask the patient to wait for half an hour, and we redo it. And if it is not getting repositioned, the most common differential in my practice is again pseudo BPPV presentation of vestibular migraine. And you start the prophylaxis and the patients improve. And I have seen one case of vestibular paroxysmia. I was repeatedly doing maneuvers, and like every day the patient was coming, and I was not able to reposition. Then I did imaging, and hyperventilation test was positive, and it was showing nystagmus. And then MRI also showed the loop. And then I started carbamazepine, and patient had improvement. That is only one case of intractable positional vertigo due to that. I had one patient of stroke, lateral medullary stroke, but patient of course had a lot of central symptoms and signs. And even now he comes for follow-up like 3 years down the line. Still he gets positional nystagmus and vertigo, like so they and he doesn't have latency. There are typical features which are described in the literature. So these are the different causes which we should remember, like which if there is no response to maneuvers for the BPPV.
Sir, Dr. Avinash, sir, yes, sir, please, sir.
Yeah, two things. One is, of course, if there is no crescendo, decrescendo thing and the nystagmus doesn't fade away, if it's a persistent nystagmus, it cannot be BPPV. One. And the other thing is, the nystagmus just should concur with the plane of one of the canals at least. So if you are not able to conquer anything, then it. Times you will get only nystagmus and no vertigo. That is also central. So these are the few things I think I can add to what has already been said by Sir Dr. Kothari sir and Dr. Vishal.
How often do you all see something like what is called vestibular, not anosmia, I forget the word. So when the patient is clearly
Agnosia.
having BPPV,
Agnosia. That is agnosia.
agnosia. So the patient clearly has BPPV, you do the testing, but he doesn't feel vertigo. And on the other hand, there are some people who just one beat and they scream and shout. So there is a difference between people, and I've seen patients who say, I get pressure in the head, I get headache, and it is actually BPPV.
Sir, that I've seen in one patient. That was my school class fellow's wife. On one day, she came. They told me, they rang me and said, "What is she? She's having severe vertigo," and she even fell down as she got out of the bed. They got her admitted in the hospital. Unfortunately, that day I could not visit. They visited me the next day. The next day, she had a typical posterior semicircular cupulolithiasis, the Dix-Hallpike test showing the Dix-Hallpike and half Dix-Hallpike both, or showing persistent the nystagmus upbeating, right torsioner, and with positive inversion test. And to my surprise, she fell on the previous day because of severe vertigo, and now she has nystagmus but no vertigo in the Dix-Hallpike position. And the nystagmus was there with the positive inversion test. So I did the vesicular maneuver and she recovered completely. At some time, I think I have posted it on the fine neurotology group. So this can occur in cupulolithiasis, and as one of the paper from the British group, I'm just forgetting the name. He was once
the London wala, I'll remember his name.
yeah. So he has published a paper.
He's Indian, but from Africa.
Okay. So he had written a paper. It's common in the post-traumatic BPPV.
It's also a question about how frequent are falls in BPPV. And can it look like, I mean, sometimes it can mimic a syncope. People think, I mean, they get diagnosed as syncope, unfortunately, in the ER, and they don't get a consult with the neurologist or the ENT.
So one of the reasons for treating BPPV, of course, is there is an increased risk of falls. But they don't fall like syncope. The person is standing and sitting and suddenly falls or feels faint and fall. Waisa nahi hoga. But they have an increased risk of falls because their balance system is not normal. Is not. I've seen patients, they turn like that and suddenly they'll fall. Not like a crisis. Avinash, Vishal, what do you all think?
Sir, I agree with you.
Falls?
I agree with you. One, the falls will be by and large ipsiversive, if at all, on the same side as the canal involved. And of course, there will be no history of a blackout or anything. And the patient will be fully conscious. That's one thing to differentiate from a syncopal attack. In fact, I don't know if time permits, I'll quickly go through a patient who just came to me in the last week. And an elderly lady, around 81 years old, still very active, doing treadmill. So while she was on the treadmill, she fell. But this time she did not hit her head on the ground or anything. So, and she says very clearly that I had a blackout. I had dimming of vision. And, she remained all right after that. That means it was not BPPV. Because if BPPV was there, then she would have had positional vertigo. Again, another day, while cleaning things in her house, she again had a blackout. She had a fall. This time she hit her head on the ground and she even went in to get a few stitches on the scalp. Now this patient landed up with me with positional vertigo. So now why I told you about this patient was, and I did the posterior canal maneuver for her and she was all right. Now this positional vertigo is gone, but again another incidence, she had a syncopal attack again. And now she is, in fact, currently she has been put on 7 days Holter monitoring. So now the point is that falls do happen. One is these falls give time to the patient to, in most of the cases, prevent falls also. So that is how we can differentiate between these falls. I mean, due to BPPV or non-BPPV causes.
Yeah, BPPV can be, one of the common cause of falls in elderly, and especially as the age increases, the balance reserve reduces. They have some visual issues like macular degeneration. They have proprioceptive deficits. They have like developing spondylosis, cervical spondylotic myelopathy. So, or maybe peripheral neuropathy. So they have little reduced balance reserve. Then the chances of fall are more in cases of elderly as compared to younger patients. That's what we
Vishal,
see.
there was a paper from a rehabilitation journal. I think it is 2023. They say that in patients patients with fall above 60 years, 1 in 4 patients it falls are related to BPPV.
Yeah, yeah, very common cause.
And then that's what I think, that's something I try to reinforce. We say dangerous vertigo only for central causes. Even a peripheral vertigo can be dangerous if it's going to in a more than in an elderly patient if they're going to fall and have a fracture. So I think we need to differentiate and change the definition of a dangerous vertigo for that. So, I mean, I think we spent a lot of time on how we diagnose. I think we should just move. Yeah, in the interest of time, I'm just going to move on to the next part. So, what maneuver? I mean, once you diagnosed posterior canal or lateral canal, what is the choice of maneuver? Is it the same? Is it a one size fits all for all patients, or do you try to change the maneuver according to the patient? Sir,
Vishal.
Vishal sir, yeah, I
Yeah,
think.
yeah.
Okay.
For if I diagnose the patient as posterior canal, my first choice of maneuver is Epley's. I go with Epley's. And most of the times I manage with Epley's, but sometimes I go with Simmons.
Okay.
And for lateral canal, the maneuver of choice, apogiotropic, I go for Appiani followed by Goffoni. And for anterior canal, like it is rare, but in my series of like I have treated around 700 patients, so I have 12 patients who had anterior canal. I go with Iacovino. And for apogiotropic posterior canal, I go with the quick liberatory rotation maneuver described by Professor Califano, where you have to go directly to the nose down position instead of the second Epley's position. So these are the common maneuvers I perform.
Okay. So, and do you change it based on the based on the patient? Is it so you said about especially, I mean, I'm going to stick only with Epley's and Simmons because that's the most commonly done ones. How do you choose between Epley's and Simmons? Is there any difference in the success rate or ease of use?
Ease of
Uh,
use depends on how strong you are compared to this patient. If the patient is very stocky and you are not well built, you won't be able to do this amount with the force that is required to generate the inertial forces. So it is better to depend on the gravity unless and until you have reasons not to believe on gravity.
One way that I have done Simont, I hardly use it now, but if we have to do a Simont, then don't do it alone. Take another well-built guy on the other side, and together you should do it. Then it becomes easier. My technician has sometimes come out with a bad back or some shoulder injury or something. You know, when they try to heave the patient and the patient resists or doesn't move. Simont is a very brisk maneuver, so you can injure the patient, you can injure yourself. So
That is very true, because lately I have been doing bascule maneuver, that is Simont and reverse Simont in succession, done multiple times. And if I have two patients that day in the evening, I have a pain in my shoulders. And in the
Yes.
morning, when I just usually forget about the pain because I exercise a lot. So in the morning, why I am having a pain in my shoulders, then it flashed back that I had done two bascule yesterday.
But I think even for bascule, try to see if you can have another guy on the other side, if possible.
Yes, but I don't have such people with me.
A bed. No, my problem is the same thing. In my clinic, the bed is in the corner. So sometimes such patients, I will call them to the hospital where the bed is in the middle, and then we have the houseman and two people, trying to move the patient. So Simont, often it's two. Do you remember, Doctor, this Alain Thierry had told some modification of the Simont where, we normally take the patient's nose down, but he does something else. Vishal, you remember?
Yeah. So what he does is, suppose we take the patient, suppose like this on one side. So he keeps the head in the same position, and instead of going from directly from bed like this, he keeps the head in the same position and takes the patient like this, from the and then he does that head in that position once you reach the other end of the bed. So instead of going from in this direction, like for example, he takes the patient like this, and then I hope you're understanding. I'm not able
All
to
right.
maybe.
I think we should request Alain to make a video and send her. By the way, Alain Thierry has studied under Simont. So he has
Yeah.
learned the maneuver
The
from
student
Simont
of,
himself.
yeah. And is everyone also is seeing Kotari sir's screen as a optokinetic stimulation, because it is moving from left to right? Like I am seeing his screen is moving, your screen.
Okay. Actually, no,
My
sir. I think
screen,
probably no, sir.
Is it
I think
moving?
that's just yours. I think that's just your connection.
Oh, maybe.
It's okay, sir. Yeah. But Avinash, sir, your opinion, sir. What is your preference for?
Yeah, actually, I have stopped believing in the difference between the liberatory maneuver and the one that is dependent on gravity. I'll tell you why. I was reading this book by Susan Herdman on rehabilitation. And in one of the chapters, what I saw was, given the biomechanics of the semicircular canal and the specific gravity of the endolymph and the surface tension that is there, putting all these things together, whatever you may do, the speed or the velocity at which the otoconia move is very, very small. It's a very slow movement. So according to that chapter I read in that book, it will not, in fact, it's very specifically written that, Simmons has no advantage over Epley's. And for other reasons also, like Dr. Kothari said, I'm also not getting, so I don't want, so I prefer a specific, for example, neck.
sound is breaking, I think.
I
No?
think yes. I think
Yeah. Sound is breaking.
Avinash,
See,
I
Uh,
think we missed the
Actually,
last part.
probably there's a bit of an unstable internet connection on my side. Am I audible again now?
Yeah. Now
yeah.
Yeah.
Yeah,
Yes,
so I
you
would
are.
use Simont in a patient with a thick neck, and cervical issue. Simont works better for these patients. In fact, Epley may just not work because you'll not be able to get the 30-degree hyperextension that you are looking at. So
Actually,
Simont
we'll
is
come to
useful.
the steps of the Epley, but I used to find Epley sometimes failing. In the third position, I would get, suppose I'm getting nystagmus in one direction. When I go to the third position, sometimes the direction was reversing. And in these patients, I would try the Simont. But I realized after a lot of days that I was doing the Epley wrong and we were not doing certain thing. We'll talk about it when we come to how to do the Epley. But nowadays, I think 99%, 95% I'm doing Epley only.
Okay.
What about the lateral canal? Do y'all, most of us I think are using Guffoni, but does anybody still use the 360 roll?
Yes, sir. In many patients, you have done sufficient number of Guffonies on day one, but they again return to you next day with recurrence of similar nystagmus. Two patients I had recently in past 6 months. In that, the Guffoni was failing again and again. So I did the barbecue roll, 360-degree barbecue roll. So that is one thing. And about the apogeotropic, I slightly differ from the Vishal. He prefers the Epiani followed by Guffoni. I first do head shaking that I showed 6 years back.
Try to convert. Yes.
Yeah. Head shaking sometimes resolves if it is on the utricular side of the cupula, horizontal canal. And after that, if it doesn't resolve, then I do a Zuma maneuver.
Yeah, I'm also doing Zuma. Only problem with Zuma is it takes so long, 3 minutes in each position. So 12 minutes for one repositioning is a lot of time.
Yeah.
And it may not work for the first time. You have to repeat Zuma.
That is true for every maneuver for apogeotropic horizontal canal PPPV.
Yeah.
And posterior canal also.
Yes,
But let me ask all the panelists, what percentage of your patients are not, I want to say that maybe 90% of patients are either just posterior canal or lateral canal geotropic. My apogeotropic are maybe 20% of the lateral canals. And nowadays we are getting, because everybody has started doing Epley, we are getting a lot of complicated. So you're getting the sitting up vertigo, you're getting cupular lithiasis. But otherwise, most of the patients, for majority of people who are not like a tertiary referral center, most of the time you will only have to learn how to do an Epley and how to do a Guffoni. That is enough to manage more than 80% of your patients. What do you all think? Because see, I think Ajay or Avinash might be getting, like me, patients who have not got responded and then they come filtered. But if the person is coming first time, 90% of the patients, 80 to 90% are just typical posterior canal and typical geotropic lateral canal. So people should focus only on those two maneuvers to begin with, is my feeling. Because you will get confidence, you should not get confused that there are so many maneuvers and so many things like that. Just if you learn these two maneuvers, you will have 90% of your patients in hand.
More important is that you have done the maneuver correctly and then you have retested the patient, not left it just like that.
Yes.
Because the
Yes.
canal switch is an important complication that occurs. So that's why it's important to that through that.
So that's
I
been
completely
questions.
agree with Kotari sir. Like these two maneuvers are very important, like Epleys and Guffoni. Majority of times that suffices actually because apogeotropic and other variants are little less common. But as you know, your practice becomes little longer duration, then you start receiving complicated cases. For example, last week I had a patient who underwent maneuver 3 times outside, and then he came to me. I in the first testing, it was I got the findings of left lateral geotropic variant. Then I did a Guffoni maneuver, and the patient came back again saying that I'm not feeling better. Then on day 3, I checked and it was on the right. The findings were suggestive of right lateral canal VPPV, then geotrophic. Then I did right-sided Guffoni, and then then he came for follow-up 2 days ago, and it was better. So it was bilateral lateral canal. So there are of course difficult cases, and but by and large, Epley's and Guffoni, if you learn, and you should maneuver for each canal rather than going for Epley's, Simmons, and like in practice you should master one of them, and you can go ahead with that maneuver.
Yeah.
So,
Just before, I know Srinivas, we spent a lot of time on diagnosis, but in a clinic, often the side-lying maneuver or side-lying test can be an easy way to look for posterior canal and even lateral canal. If you don't have space, lateral canal is easy, but if you don't have the space to do a proper Epley, then you can just do a side-lying.
Yeah.
Turn the head to one side, fall. It's like what we do for Simon, but just go one side, forwards. Or Brander of exercise, just do that.
I must confess that is my go-to testing, sir. That is my go-to maneuver because I sometimes have to do it work inside a very small room. I have a half a couch. This becomes very easy to do. Side lying is my easiest to do.
Yeah. But my question here is, does the speed with which you bring the patient down matter? I feel that if I bring the patient down fast when doing the side lying maneuver, there is a higher chance of eliciting. I don't know about what the other panelists feel.
Avinash sir, you want to take that? You want to?
Yeah, basically, sir, I don't think that really makes much of a difference. Like I was saying, given the biophysics of the canal, and I mean, in fact, gravity is the only thing that is doing the job. We think that we are speeding it up, but it doesn't really happen. That's what I have personally also seen. Like, for example, I do Guffoni a lot. There are patients who are kind of very lean built, and I can take them down rapidly to the position. And there are patients who are obese and not so fit. So I have to be very careful with them, and I take them down to the Guffoni position slowly. So I have not seen any difference in the results practically.
I won't completely agree with Avinash about the speed not mattering, because definitely for Simon that has been shown that it matters, and I think that is why Dr. Bhandari and that group has come out with that paper. It's a nice paper, and as well as the simulation where they've shown that the Simon Plus works better. But the problem with Simon Plus again is you need space, for the head to go down below the thing. But nowadays I'm not using Simon only, so it doesn't matter. But I think that speed, even Michael Stroop has shown that if you bring slowly, then the particles don't get that momentum, because in Simon you are not using gravity. Gravity will not help you in Simon.
In any case, this is a very commonly encountered problem in horizontal canal BPPV. Then when you do a head yaw test, sometimes you don't get a nystagmus on head yaw to one side. Then you do it to the other side, you get some nystagmus. And then you get again on the initially tested side, you get a very brisk nystagmus.
Yes, yes.
So speed could matter, or it could be a reason that the autoconical particles must be sticking to the wall of the horizontal semester.
Yes. Definitely they're stuck sometimes. You check 2-3 times, and the third time suddenly he gets the severe nystagmus.
It is more common in horizontal canal BPPV.
Yes.
How do you feel, Avinash?
Yes, very true, boss. In fact, sometimes there's hardly any nystagmus on one side, and the other side you do. At that time, I think started moving, and then you repeat the macular pagnini, you'll get it on both the sides, and you'll be able to come to a proper diagnosis. It happens.
More brisk. Yes.
I think that is where your clinical suspicion matters. It just because the first test is negative, we don't drop it. If you still suspect BPPV, we retest. I think that is what we need to tell the audience. And and when we are talking about the maneuvers about the Epley's and the many people have raised questions. How do you, if somebody is going to have severe symptoms, severe nausea, how do you go about doing the repositioning for them? because I've had patients who actually threw up when I was doing the retest. I mean, when I was doing
Ah,
the test, they just
throwing up.
started vomiting. How do we do a repositioning on them when they are so symptomatic?
Okay, so when I started out in practice, I was not one. I have a video of a patient where I took him down and oh shit, here it comes. And that guy went away. He didn't come back to me ever again. Huh? So you have to warn the patient that we are going to do this. If you don't want daily vertigo, you have to tolerate it for 5 minutes. You will have it for 5 minutes, but it will go away. So you warn them. You tell them that you are going to get vertigo, and getting vertigo itself means the maneuver is successful. But it will be there for only one time. So somebody's asked that question, how do we tell them? You tell them, no, that do you want vertigo every day or you want it once and get out rid of it? And keep a plastic bag ready because you don't want them puking in your clinic. So keep that ready.
So we
You
keep a
see,
bucket, we keep a full bucket ready, proper
you,
bucket rakha hua hai.
you can see buckets too in my clinic in my videos. So these buckets are very essential, and sometimes every time you take it to one of the positions of the apply, they will have vomiting, and after 1 to 2 times they it might stop. And mostly the antiemetics you give ondansetron, etc. They do not really work. The only thing that works is that if you do a successful repositioning, even in such nauseated and vomiting patient, it will work.
Is there any
I do use ondansetron in some patients who have this before, and I also use clobazam 5 milligrams as an anxiolytic for those who are very scared. So give it to them, and after about half an hour, do the thing. So some patients are extremely scared and they scream and shout, and all the remaining people in the clinic might run away. So it's better to give them.
Yeah, and another strategy is keeping that room where you do the positional testing and maneuvers very cool is another strategy to reduce the vestibular autonomic response. That is one thing. Secondly, as Kothari sir said, it's very important to tell them. Even I have some patients, you take them to Dix Halpai position and the patient says, doctor, I want to leave now, like because and you're ready with how to do the maneuver, like go for a please and turn the patient's head, but the patient says no, I don't want to undergo. From there itself they don't consent. So it's very important to tell them that we have a consent form. So we tell the patient that you might get nausea, vomiting, and again keeping the vomiting bag ready is very important. Not searching when it starts happening, it happens that suddenly the patient might feel, and at every position it's very important to ask, are you feeling like vomiting? Sometimes it can, it is very important to give time to the patient, because we are very like interested in doing the maneuver, but patient comfort is also important. And I have treated them with ondansetron. I treat them and with injections. I had one elderly lady who was ready to undergo maneuver. You doctor, you do it. Like she had repeated vomiting. I gave 4 mg initially, again 4 mg. 3 times she underwent same day, but and it got corrected. Like she was better. So it all depends on patients how they take it. Like the vestibular autonomic responses differ from patient to patient, and so we should be ready with these strategies for dealing with vomiting.
what
Somebody said that they use injection prochlorperazine,
that's
but
what I
I
want
wouldn't
to
use
ask.
that
That
because
was
then
Dr.
you'll not
Ramesh
see the
Rohiwal.
nystagmus.
So that was Dr. Ramesh Rohiwal, but I, don't totally disagree with him. I'll tell you why. Because supposing you have done the Dixolpide test, you have seen the nystagmus once, okay, and now you know, okay, it is the right posterior canal, and after the patient vomits, I send the patient back home, tell the patient, before leaving home, please take a tablet of 5 milligrams of mouth dissolving prochlorperazine and come to me. I'm very comfortable after that. The patient is very comfortable after that. And fortunately, I have got the nystagmus. Now, the intensity may be less, but I have got the nystagmus most of the times. And in fact, I can very well remember if not the names, the faces of those patients, few of them in whom I have done this. So, of course, I think the injectable is out of question, prochlorperazine for me. But yes, the tablet does work and it really helps.
But has it happened that they take a tablet And when you are repositioning, you don't see nystagmus?
Sir, I have seen the nystagmus also.
But
It is
no, I mean,
subdued.
every time is it seen? Because what we find is patient takes a tablet and has come. Often we don't see, and we have to send them back and tell them come again after 2 days after stopping.
So more often I have seen that whatever the patient may be taking, some degree of nystagmus is there. At least that's
Okay.
my experience. And in fact, in those cases where I've suspected that I might not be getting the nystagmus and the patient is called the next day or the day after, these patients turn out to be more often positional vertigo due to vestibular migraine. That's my.
I agree with Avinash because in my practice, I don't believe that the nystagmus of BPPV is suppressed by any of these vestibular suppressants. That is
Vertigo gets suppressed, not the nystagmus.
plegic drugs, or even by the beta-histine, which is not a plegic drug.
Okay.
We should do a study where we take a BPPV patient, give them a tablet, and see the effect on the nystagmus. Because I feel the nystagmus gets less, but this has been discussed earlier also. It's so easy to do a study, do it before and after. See the nystagmus before and again give a tablet and do it after and see does it really reduce only vertigo or does it reduce nystagmus also? Because it's acting at the level of the vestibular, the cochlea and the vestibular nerve. So I think it will reduce the nystagmus also. But I mean, it's rather than saying what we think, why don't we do a study? I think it should be done.
I think that's a
And
good idea, sir.
yeah, just last comment. Apart from nausea, vomiting, I have seen only one patient where the patient had BPPV, and because of that severe autonomic response, he actually had a sweating and bradycardia and syncopal episode. Actually, he had
Yeah.
neurocardiogenic syncope. One patient I had.
I
Yeah.
had a patient, Vishal, very similar. The patient would take him down and his heart rate would go down to 30. He would get a heart block. He had a sick sinus syndrome and this would trigger it. So we
Yeah.
told him, you put a pacemaker first and then we'll do it. He said, no, I'm not doing. So we admitted him to hospital and did the thing. And luckily nothing happened.
And interestingly, this
And one
patient,
one patient again, sorry, one boy had come who was screaming and shouting. He just would not allow. We had to give him intravenous diazepam and put him off to sleep and then do the Dix-Halpine,
No.
and it went away luckily.
Okay.
So
yeah,
he
yeah. And
required sedation.
interestingly, the VNG also recorded the sweating actually. Like there was no sweating, and during the Dix-Alpine nystagmus and sweating was there.
Yeah. Well, what do you do if a patient has, I mean, if a, I mean, typically patient with severe compulsive myelopathies, Parkinson and PSP who already have difficulty moving there, like significant rigidity. What about positioning in those patients, sir? What is your recommendation for repositioning? Just,
Obviously, you can't do a CMONT. You can't do a CMONT.
Okay.
So we can still do an epi, and I had a patient of ankylosing spondylitis where we could not write. So we did it on a tilt table. So we
Okay.
let him lie on a tilt table and took the table itself was tilted 30 degrees down, and then we just rolled him over. So you'll have to do some sort of thing. Sometimes your patients post-traumatic have a fracture or something, and you can't do anything at that time. So sometimes
So
willy-nilly you have to give them vestibular suppressants for a few days and call them back later.
I think these are the candidates for the chair, like where you can fix the head and do the
Yeah.
externally the patient's need for of flexibility.
I think that's a very good point. I mean, I actually would have thought the Semont would be easier to do because you don't have to hyperextend the neck. You're doing the Semont. It would have been easier if they have a fracture or something. You just put the collar on and do it. But as I said, I mean, it is a very
Simon, you're doing so fast. You're doing it so
that's the
fast,
hard
you're
part. Yeah.
scared.
Okay. I think that's a good point, sir. I mean, somebody's actually raised the question about, I mean, you mentioned that in these patients, you just give them a bit of sedatives. Somebody's actually asked, is it worth all the trouble of doing all these measures? Because many patients sometimes have symptomatic relief in a few days anyway. So why don't you just ask them to wait it out?
Okay. So again, that's a thing. So why learn maneuvers if you can just give Vertin? Huh? No. So because the patient is not completely relieved, the chance of turning into PPPD is much higher if they have this feeling of all the time going to have something. And once the patient knows that the problem was just one tiny particle in the wrong place, then somehow the whole reaction to it becomes less. But if they don't know why it is, if they think it's spondylosis, if they think there's less blood supply to the brain, even they may feel better with a tablet, but they are going to become neurotic. So if you don't want the patient to become neurotic, you got to treat it. And I think you can't rely only on natural history for the thing to go away, because they tend to recur more. I don't know about studies, but I think after repositioning, the chance of recurrence is less than if the person has recovered spontaneously. But I don't know what is the experience of everybody else. That we see patients who keep getting attacks every 3 months or 2 months, and they keep taking Vartin, and you do a repositioning, and then at least for a year or two they don't have.
Yeah, in fact, you become very serious practitioner of vestibular medicine when you stop using symptomatic medication in BPPV. The day when you don't rely on go with symptomatic management, you start thinking about which side, which canal I want to learn maneuvers. That is the day of like it will change. That day is very important. Like, and that's why it is not in only like cases, complex cases, we can go for that medication, but we should not. 99% of the times we are able to manage. Many a times, like I will ask the panelist how many percentage they are not able to manage with the maneuvers. I think everybody will agree that most of the patients we can do the maneuvers, like most of the patients.
And sir, what about retesting after a maneuver? We do the test. How do you know it's been successful? Do you do it immediately, or do you wait for a day? So what is the usual
I think
protocol?
it's going to be different for everybody.
Yeah,
Let's see what
that's why I wanted to
everybody.
ask the opinion. So that's the whole point of the panel discussion.
That depends on the type of practice you are doing and the profile of the patient also. Because if the patient is coming from almost next door, I don't waste time there, and then I call him in the evening if I'm seeing in the morning, or I call him the next day. But if the patient has come from 35 kilometers away, then in that case I ask the patient to wait outside for about 20 minutes. And please don't ask me what is the criteria for that 20 minutes, because for me it works. Some people say 45 minutes. Dr. Ajay Vats says 45 minutes, I remember.
No. What I do, if I see the patient in my early morning OPD, which is between 9 and 1, then I do the maneuver. I call him at 4 p.m. again. I read for retest.
Okay.
And if the retest is negative, I find lot of canals which is there, and then I treat there. Then I give a option. If the patient has come for say, around 200 kilometers, there is a remote possibility that when you sleep tonight, in the night you may get vertigo attack again, or in the morning. So you have the option to visit me tomorrow at 9 a.m. So virtually I am testing after 1 hour and at 24 hours in almost every patient. At least I give option to them.
For me, I check immediately. I check as soon as I do the maneuver. I do it immediately. I record it. I show them that, see, the same thing. 2 minutes back, when I put your head down, you had severe vertigo and spinning. Now you don't have. It is gone. So I check it immediately. If it's not gone, I repeat the maneuver. If it's not gone, I repeat it a third. So I repeat it until it's gone. And if it's not gone, then we'll talk about what to do when you are unable to do. We do some things at home. We tell the patient to sleep on the normal ear or do a home apply. I think we'll talk about that. But I want to know from the other panelists, why not check immediately?
So fatigue.
No,
Fatigability of the
fatigue. The guy
established.
had severe vertigo. You did his maneuver, and you do next time, and there's nothing.
No,
Probably you
no.
have succeeded. Then you send him home. But if you take it down and he gets again, you have failed.
No, one is fatigue, as Bijlani sir said. The second very important reason is there is something called otoconial reflux. Because when you do the maneuver, they go into the utricle and they have not settled. They are still in the endolymph. There is a chance that when you do the positional testing, they can come back. That is called otoconial reflux. So you
Come back or
may,
go into another canal.
Yeah, even going to another canal. So it's
That is
very
that is
that
important
they keep
because
their head stable for some time so that they settle down in the utricle from where they have come. And in my practice, what I do is I ask them to sit for 15-20 minutes. Invariably, it goes to half an hour because I go to see another patient. So it becomes very, it is variable, but minimum 15 minutes I wait for recheck. Yeah.
see, Vishal, with my practice, I ask them to remain upright till I test
Yeah.
in the evening. So that is the
Correct.
postural restrictions. It's not recommended from the society, either the Barani or the AOHNS, but postural restrictions do help to prevent the canal switch.
Yeah.
See,
So,
the
Yeah, so I feel that if I repeat the test and if the person does not have nystagmus, maybe it could be fatigue, like Dr. Bijlani is saying, or maybe I have succeeded. But if I get the same nystagmus again, obviously it has not worked. So that happens many times. We cannot. How can we say that the EPLI has worked in the first time that you've done? We do it and we tell you come tomorrow. But if you don't test it immediately, how do you know it has worked? I know there are signs which tell that yes, you got the downbeating and you got the liberatory nystagmus, etc. But still, it feels good to know that yes, it is gone, and patient also feels very happy that yes, it was there, it is gone. So I don't find canal switch more or recurrence more just because I retest. I have not found that.
See, Sudhir sir, I am doing 5 applies in one session in the morning. So every time I take the patient to the first position of the apply, that is equivalent to the Dix sulfide testing. So
Correct. So you are
during,
doing five. So you are also repeating.
yeah,
You
I
are
am
also
repeating.
repeating.
If I have one session is completed, then I will retest after in the evening OPD. So that is,
So when that one session, one apply maneuver, then you don't stop after one apply maneuver.
yeah,
You
yeah,
check again. You do it again.
yeah.
That's what.
So many of the canal switches and canalage jams that I picked up by doing the apply maneuvers multiple times.
Again.
Yeah, yeah.
Yes. Yes.
okay. So I think there's a lot of variation in, so I
Yeah,
think,
a lot of it. So
yeah.
Dr. Watts, please let's repeat again. When you do an apply, you do it 4-5 times for the same patient to till it's gone.
I do it 5 times in one session. Whether I am getting the nystagmus again during the dexalpike position of the apply maneuver, because many of the particles are so small, presumably, that they don't create any nystagmus, generate any nystagmus. So I do it.
Okay, so you are actually going one step ahead of me. I do it again, check if it's not there, then I stop. You are saying even if it's not there, you still do the
Yeah,
apply.
I do 5 times and then I call it in the evening
Okay.
OPD. And many of them time they have the same type of nystagmus in the evening OPD. Sometimes they change canal to the horizontal, and sometimes there is a canal jam. And even during the fourth or fifth maneuver, I have seen that canal jam occurred, switch occurred, and it was immediately followed by canal jam. The I have that published that paper and I have presented it in many conferences also.
So one question to the panelists. In about 10 to 15% of the patients, when I do an apply, the first time you get the typical upbeating. The second time, I take the patient down. Patient has no symptoms. The same patient who had a lot of symptoms, he has no more vertigo, but he shows downbeat nystagmus. So my hypothesis now, this time the particles have gone a little bit to the short arm, but he's not got any symptoms. So I leave it, and when he comes next day, there's nothing. So
That is one of the
I think that is
hypotheses.
what happens. But
That is one of the hypotheses of the Bela Bukki group and the Camby article. But in
Is
the
it because of
recently,
autoconial reflux? Because the autoconia are coming
yeah,
back.
they've gone there. Yes.
but if they have gone in the short arm, the nystagmus in the short arm side cupulolithasis will develop will depend on the shape of the cupula, not on the type of the where the cupulolithasis on the short arm side or the long arm side. So anything in any case that
No,
Dix-Alpine.
they are on the why I'm saying short term side because now it's downbeat nystagmus and opposite, but he has no symptom.
See, it could be there. This is one of the publications from Hermat in year 2022, where they have opined like this But I feel that this could be epigeotropic posterior semicircular canal BPPV, that we have not successfully repositioned it, and the abscess is stuck or partially jammed in the non-ambulatory.
Agreed. But I think, see, most of the people who are not doing immediate retesting will not be able to say. But since you are doing that and I'm doing that, I think we should look at what happens to these patients when you have done an immediate repositioning. Immediately after that, what is the pattern of nystagmus which predicts whether you have succeeded, whether you have failed, whether it has become a epigeotropic or a persistent short arm? It's worth looking at.
Yes. Are we running short of the time?
I
Smith?
think we have some time yet, sir.
Yeah, the important
So I
questions
think
can be
before you
taken.
finish, Srinivas, before you finish, the one very important thing is what instructions to give to the patients
I think
after
that's
you
what
have
we're
done a
coming to
repositioning.
that. So two, three questions I have. I'll give you the questions now. You can take it in order.
Yes.
I don't want. So one is, what do you do? I mean, after repositioning, many patients will have a bit of dizziness. They won't have vertigo. They feel very unsteady. How do you manage that? The second question is there anything you tell the patient to do when they go home to prevent recurrence or to improve the symptomatology? And third thing is, what else can we do for, I mean, if the patient is not resolving in clinic, I mean, sometimes you're just in a very busy clinic, you can't spend a lot of time. Is there any home exercises that you recommend before they come back to see you again? So that's three questions. I'll just leave it for now. And I think with that, we'll be able to end the session on time. So, yeah.
See, one thing, precautions that I give, because I take it out from the history. Young patients are coming, many patients who are politically very active. So in the night, they are surfing the YouTube and the social media with abnormal neck positions in the long terms of neck positions in one particular position, like this or like that. So in those patients, I instruct them, if you have to see the WhatsApp or television, don't see in the recumbent position, see in the upright position. That helps many patients for the recurrences. That is one of the things I do, and rest for others.
Do you, if I see a patient of right posterior canal or right lateral canal, I tell them to sleep on the left ear for a day or two as far as possible, so that whatever little particles are remaining, we do what is called a forced prolonged positioning treatment, which is part of treatment. So earlier, when you could not reposition, you just tell the patient to lie on one ear and the particles will get repositioned on their own. So I tell them to do that. It's not absolutely mandatory, and the patient of course will sleep a little bit on that side, but you tell them majority you sleep on the normal ear. So do you all do that, and do you think it's useful?
Do it for
I
lateral
agree
canal
with you
BPP.
100%. So I fully agree with you, and that where the lateral canal is concerned, it is really very helpful. And if not helpful for the posterior canal, it is preventive.
Yes.
What Vishal was talking about, the flow back of the otoconia. So yes, definitely, and there is no harm in it, no sir. And we know it is useful.
Absolutely.
So these post-maneuver instructions do help the patient. In fact, I write it down and give it to him. He does remember.
And one more thing, what Dr. Ajay was telling, that you
You are
tell
right.
patients to sleep on both sides. Some patients tend to sleep mainly on one side. You tell them to sleep normally also on both sides, so the particles don't get collected in one side.
Yeah,
That's also another point, sir. But for me, I mean, lateral canal particularly, I tell them 2 nights, in fact, that comes back to the forced prolonged position as a therapeutic thing. And like we were talking about, how sure are we if all the particles have gone? How sure are we that the particles in the might give the patient in the late?
Yeah.
Okay, your sound went off.
On
Maybe
the
you can try switching off
nights.
your video. The sound might come better. Try switching off the video and see.
Doing that, sir. I don't know.
Yeah,
Connection normally it doesn't falter.
suddenly it seems to be breaking in between, sir.
Now.
Yeah. So the last part of your talk, of your sentence, we couldn't hear you, sir.
Yeah. Meanwhile, can I comment about this?
Delhi over the last.
Yeah,
Go ahead,
regarding the
Kishan.
regarding the precautions, as Kothari sir said, for lateral canal geotropic variants, yes, definitely. Even if I have done Gufoni, for right geotropic lateral canal, it's a good idea to tell the patient so that the canal it will help. But for posterior canal and anterior canal, I don't give precautions. And giving precaution is while giving precaution, it's very important to tell the patient that just follow it for 3 days. I tell them about just 3 days, because what happens, the patients have tendency to overdo because they had that vertigo severe. I have seen a patient who was treated for BPPV outside, and was told like 3 years ago that to not to just for and it is not specified. If it is not specified to the patient not to lie down for specified day, the patient will overdo. There is a tendency to overdo the treatment. So and he was consistently lying down like that from that time, because that feeling was so severe. They think that it is preventive, but
So
actually
I
we
had
are
a
doing
patient who did that for
therapeutic
15
care.
years, who refused to
Yeah,
turn her head for 15 years. And I told her, she got very angry with me. She said, no, no, senior doctor told me don't turn to the right side. You're telling me turn to the right side.
and I also
No,
see
actually,
several
sleeping
patients.
on one side is a risk factor for getting
Yes.
BPPV.
Yeah. And I also see patients who are who undergo epilepsy, and they are told to put a lot of pillows, and they sleep in a very awkward position. Even the guidelines don't recommend like telling the giving the precautions. I don't do it, and I haven't seen any recurrence because I haven't told any like precautions like this. So it varies actually. The practice varies with different, but I follow that. Yeah.
So
One
Avinash,
more
I wanted to add something. Sorry.
One more thing I want to add is there in the apogeotropic variant of the horizontal canal BPPV or the geotropic, the position for the forced prolonged positioning is the weaker nystagmus. That is the involved side in the apogeotropic and the non-involved side in the geotropic variant of the lateral canal BPPV.
Yeah.
Okay.
Yeah. So the side you have to, of course, diagnose properly.
Okay.
Um,
What
uh,
about what about the brander of exercises or any rehab exercises? Is there any role for them?
I use them in patients who have mild residual symptoms. So I use that. One more pace, which is little controversial, is when somebody keeps getting recurrences. I tell them to do Brander of exercises. I tell
Yeah.
them instead of 5 times, just do it once a day. Every day in the morning when you get up, do it once. If you don't have any vertigo, no need to do more. If you feel slightly dizzy, do it 5 times. So I don't know if it works or not, but maybe what my logic is that suppose there are a few particles getting dislodged, then do it 5 times. If there's just nothing, no symptom, then you just do it once. And I have seen those patients who keep getting, there are some who get 4 5 times. So uh, maybe Branderov helps in these patients.
Yeah.
Sir, there was a recent paper from the Marco Mandala group from Siena, Italy, recently published last month only. They had seen 153 patients with peripheral positional downbeat nystagmus. And now this could be even apogeotropic posterior semicircular canal BPPV or anterior canal BPPV, or this, as we say, the short term posterior semicircular cupulolisthesis. And in all these patients, they advanced Brender of exercises, and around 95% they recovered over a period of 1 month. But this study is from 2012 to 2016, so it's a relatively older study which is published later on. So this is one of the studies, but no definite guidelines cannot be made because they have done a given a blanket therapy to all patients with the peripheral positional downbeat nystagmus.
See, the only problem with Branderov is if the person has very mild symptoms, you can ask them to do Branderov. You don't need a VNG, you don't need to diagnose which canal, and it will affect, I mean, it will treat all the canals. But the problem is that if the patient has severe vertigo, he will not do the Branderov, he's scared to do. And if he does it, he might move the particles into multiple canals. So then when he goes to Dr. Watts will find it very difficult to reposition because the particle has gone all over. So if somebody has severe BPPV, don't do Branderov. If there's very mild symptoms, Branderov is better than Vertin.
Okay.
Yeah.
Okay. And
Yeah. In post BPPV dizziness, I routinely tell them to do Brandarov. That is the one situation where we are not able to reposition, then Branderoff is habituation. It habituates also, and the particles, the clump goes into smaller particles, and natural resolution happens in this
But
case.
there is
What
a
about home appli? Does any of you all advise home appli? I use
no,
it.
no more anymore.
No.
Not anymore. Yeah, once
Even
a
I
month.
advise
don't.
it.
Even I don't.
I advise it in some patients where I'm not able to get it. And it's very easy to do. I mean, you tell them to take a pillow, put the pillow and sleep like that, like this, and get off the pillow. So they don't have to get their head outside the bed. Put a pillow, but not below your neck, but below the shoulder. So there are a number of images and things, people who might not have it. You can just look for home appli. It's quite useful in mild cases. But
Uh,
you need to know which canal is affected.
I
Yeah, it's
use pillow
very
in
important.
every case, unless I am not getting it repositioned. But the pillow is thick, 4 inch thick, and I change it every few years because it get to the size of 3 inch after few years of use.
In desperate situations, yes, we can, on video also we can guide, because one of my patient with BPPV, she went to Russia and there she had an attack. So on video I guided, but it becomes difficult, like, because the patients don't know, their relatives don't know the angle. So it becomes difficult, but in desperate situations, yes, we can
In
tell
Yeah,
them
you
to.
times of
can you can actually
medical
treat.
legal issues and all, medical legal issues and all, I'm very careful about it. But then very recently, relative of mine, uh, and with epigeotropic variant of the lateral canal, I sent him a video which I have made on one of these people who work for me in the clinic, and I sent him the video, Zuma maneuver, and this person was able to perform it, and in 2 attempts he was relieved of the symptoms, and in fact he has made videos of his nystagmus and everything and sent them to
Wow.
me. I'm saving them because that can be another thing to show somewhere in a conference or
Very good.
something. So when you're sure that the patient is related to you, patient is close to you, it's fine. But then, like if you're otherwise, I think I would not. And moreover, if I do it for a patient, I will not charge for it, because once you charge for it, then it becomes a business relationship with the patient. I mean, although uh, things are so bad nowadays, it's best to make sure, tell the patient, I'm doing you a favor and I'm not charging you for it.
No,
Yeah.
no.
So
Even even
I have
even
two
then there
three
is a relationship, a
Now, there
professional
is a risk.
relationship.
See,
Even if you don't charge.
legally there
I
is a
have two anecdotes for this. I had one patient, my brother was in China that time, and he called up, I'm getting vertigo. So this was 11:30 at night, and he tells me, I said, okay, sit up. Is it there? He said, no. I said, chalo, it's BPPV. Then I told him, now turn your head to the right, fall on the right. He said, nothing. I said, turn your head to the left, fall on the left. He said, now I'm getting. So I diagnosed left posterior. I told him to do a CMONT on his own, and it went away. So you might be lucky sometimes.
Okay.
Then another patient, one friend of mine was in Bali that time, and he called up, I'm getting vertigo. So I did a Skype call and I told him how to do it. You know what happened? 2 years, this guy got cured. 2 years later, he tells me, Sudhir, there is one patient in Pune. This guy is in Bali. He tells me there's a patient in Pune. He's having positional vertigo. I tried those things you had told me, it's not going. So I've asked him to come and see you. So कुछ भी होता है. And then thirdly, there was one patient I was treating in Pune with BPPV, and her daughter got positional vertigo, and she was in New York. They said, we can't get an appointment for a doctor for the next 1 month. Can you do something? I said, I don't treat somebody in USA, but she said, okay. And the girl in USA got somebody to take a video of her eyes, and it was right posterior canal, and we told her to do a CMONT, and it went away. So it depends. I think you can treat. In the times of COVID, I treated a number of patients online. So now we
Some
don't need, we should not.
some questions are about the maneuvers. I just to tell you about the participants that I have a YouTube channel on which I have many talks as well as the repositioning. It is almost free, and most of the are open to the, and even my upcoming talks in various conferences, they are still unlisted. Once I give those lectures, they will be listed open for everyone. So you
So,
can subscribe to my channel. This is no not is a totally free channel. Nothing I get out of it. because all those dirty content, you get a lot of subscribers and views. I don't get earn a single pie from here. It is for
Yeah,
the
we also
education
have
purpose.
the Forum for Indian Neurology Education channel. There are a lot of videos on that.
Yeah.
And you can see there also number of videos on Neuro Otology. So if I find neurology, just look for that, and there are a number of videos there. Of
Yeah,
course, there are
from the
videos
international
on
speakers.
So before we
number of
conclude,
videos.
so I think one last question before you go. Very, very simple thing. What are the common mistakes with an Epley maneuver that you think will make your outcomes better? So we'll conclude with this. This is the last thing I wanted to discuss with you.
Okay, let
Common
everybody
mistakes.
go, then I'll tell, because I have learned something quite
Yes.
new
This is
recently,
something which
but
only comes with
I'll go
experience.
last.
I want you all to tell us. I don't think any book is going to teach us that. So, Dr. Avinash, sir, please.
Well, one is not turning the head by 45 degrees properly or overturning it. Overturning will not bring the posterior canal into the sagittal plane, right? Then, when you're bringing the patient down, you have to tell the patient to maintain that angle. What happens is patients tend to again turn more to this side or more to this side. So, you have to maintain that angle while bringing down the patient. Once the patient has he's in the supine position on the table, that 30-degree has also to be maintained. One, that 30-degree is to be proper 30 degrees. It's 10, at least 20 to 30 degrees. If it becomes 10 degrees, then you're not going to, your maneuver is going to be a failure. Number two, when you're turning sides, say for the right, now you're bringing from the right to the left, the body should not come up again because patients tend to rise, So you have to tell the patient, don't rise. It's only your neck that turns. Excuse me. And then finally, when you're going to put the patient in the nose down position, again, now the body has to roll in tandem with the neck. The position, that angulation should not change. So I tell them, think that you are a log of wood, roll over like that. And then eyes open, look to the ground. I use VNG goggles, so eyes should always be open. And then when you're finally making the patient sit up, some of these patients, Dr. Watts will tell you, they have a tendency to fall back.
Yes, I'll reply to
And
that.
yeah,
You finish,
now you can take
Doctor.
over. You can take over from here.
Yeah. Two things I do nowadays during the position two of the apply. If I am using that conventional thing that is head hanging at the edge of the table, I try to hyperextend the neck beyond 30 degrees, maybe up to 60 degrees. That's what Apple wrote in one of the papers. And in the nose down position, the third position of the Apple, I do not take the rotation beyond 135 degrees, and then again also hyper extend the neck. The hyper extending the neck in that is has been recently found useful as a Shigeno correction by preventing the anterior canal crisis and the Tomarkin like phenomenon as the patient is taken up from the third position, the completing the apply maneuver. That's what I am practicing recently in past 1 month.
So I think that sums it up.
Yeah.
So Vishal, do you want to say something? Because I learned some lessons recently. I want to tell about that. But
No, because both of them have summarized everything, all the
okay, so
angles.
the one thing I used to do, the mistake I was doing was in the second step of the apply. The first step, when you take the patient down, head to the right, and you take the patient down, you get brisk nystagmus. So that is very nicely seen. And I used to wait till that nystagmus stops and then turn the patient to the left for the second position. Now, this position, usually I would not see anything happening, and so I thought this position was not important, and I would often go into the third position. So that was the mistake I was making, because when I took into the third position, sometimes we would get a reversal of the nystagmus. Sometimes we would get upbeating nystagmus, which would tell me it is working, but it was still wrong. So now what I've learned is that second step is very, very, very important. You hold it for a minute and wait. Even if you don't see any nystagmus, you don't see any movement, just hold the second step for some time, because the canals are just slightly tilted this way. In the first position, the canal is vertical, so you see a lot of nystagmus. In the second position, the canal is like this, so the thing flow is very slow, and you will not see prominent nystagmus. But still, let the particles go till the bottom, and then when you go here, then you will get straight downbeating. So I used to do a mistake that we used to, in the third position, tell the patient to turn nose down and do that. Now, recently we have seen that how that can predispose the patient for the particles to go into the anterior canal, and when they come up, they might get that crisis and fall down. So, like Dr. Watts said, in the third position, make sure you don't go beyond 45 degrees. I will post a video of what we had done and what was wrong. I'll post that sometime in the group. You don't go beyond 45 degrees and lift up the head. That is the Shigeno modification. Dr. Shigeno has come out with a very nice paper. What modification you should do to avoid this crisis. Earlier, the crisis was being blamed on particles going into the canalith, but he's come out with a very rational explanation that crisis happens because particles from posterior canal go into the anterior canal because you've taken the head too much down, and then when you get the patient up, the particles come down and they suddenly will get that crisis and they can fall. It's very dangerous. So I'll post that video. The patient falling is not mine, but Ajay, somebody had posted a video
Yes.
from the clinic, somebody
So
falling,
Dr. Ramesh has got that video. That is
Yeah,
from
so
Gujarat.
Ramesh, post that
Not his
video
patient.
again. People should know that BPPV repositioning, after that, it is dangerous. Patient can fall, can get a bad head injury or fracture neck femur. Post that video again, please. And I think you have to be careful. Don't go more than 45 degrees. Lift up the head slightly, like Ajay said.
And I have a question to Vatsa sir and all of you, that is there anything like Shigeno is to prevent the postural crisis, but is there anything in the maneuver we should take care so to prevent the residual dizziness? Anything has like any study or anything you do in the practice?
Residual dizziness, if there are 2 or 3 causes for residual dizziness. One is you have not done your job. The BPPV has not completely gone. Some particles are still there. So when you do it, you will see some nystagmus. Second cause could be canal switch. The particles have gone into some other canal and they are still there. The third one is the patient has got PPPD. See, what you have to understand is the patient his ear was sending wrong impulses to the brain. When he was lying on the left side, the room was not spinning, but his ear was telling him that the room is spinning. So his brain is now getting wrong messages. So even if you have repositioned him, the brain has to take time to relearn the normal thing. And that is what happens in PPPD. So you expect that they will have this. Give them rehab, give them some anxiolytics for some time. Or if you believe in doctor, this one, you give beta histine, whatever you want to do. You may want to give it for a few days, but I feel that treat it as PPPD. Tell the patient that your ear was giving you a wrong message. For some days, you will feel dizzy and it will go away. It usually goes away with rehab.
I will add one more thing before adding triple PD. I will check for the residual dizziness coming from short arm. That is a form of intracanalar migration from the
Yes.
long arm to the short arm. That would be tested by the half distal pike or the augmented
Or
half distal pike.
posterior epigeotropic form. It could
Yes.
be it has gone there and stuck there, epigeotropic.
Yeah.
Something.
Recently,
You
I
have
had
not
posted
done
that.
it completely.
Yeah. So that is one thing. And as far as a recent paper, I think no, I cannot disclose that. Okay.
Okay, I think we've run out of time and we had an exhaustive discussion only on the typical forms. It's good that we didn't take up the atypical. We'll do that on another day, I think. Any closing comments from the panel before we close this session?
So
Yeah, it was a
your decision not to put my talk at first was good because it has already crossed the time.
Yes.
yeah, because
Somebody
session
was
is
asking what is Dr. Watt's YouTube channel. I have posted that. I'll also post the Fine Ka channel. And Dr. Srinivas and Dr. Pawar, I think great job. I think I'm very happy to see so many people interested in BPPV and Sunday evening 75 and 50 still around. Great job. Thank you.
Thank you, sir. Thank you, sir.
Okay, bye.
Thank you.
Bye,
Thank
everyone.
you
Good
very
night.
much.
Good night. Bye.